Would the other discussants for the ulcerative colitis part like to come to the podium? Thank you.
And we're open for any questions, and please also feel free to electronically text us. I might start things off, Tonia. It's a beautiful presentation and video and experience. I was wondering if you could share with us if you use, what camera you use. Do you use a flexible tip camera? Do you have any experience with that? I saw you used articulating instruments. What is your norm in terms of instruments, or your preferred in terms of instruments at this point? And then additionally, it's always challenging to get a stapler low in the pelvis, laparoscopically, and especially single port. Do you use a vertical transection or a side transection, and what kind of staplers do you use size-wise?
How many questions was that?
That was one question. This is called rambling thought, please.
Okay, camera. I've tried most of them. I've actually stuck with a 10 millimeter, 30 degree camera. I do use the bariatric length camera with a right angle connector on it because I find that easier. I have tried the flexible tip, but where the instruments are so close to each other, I found that the other instruments will often bang the flexible tip, and then one loses the horizon.
So your preference is a longer length bariatric, 30 degree?
1030, yeah.
1030.
As far as instruments, early on we did, as you saw there, use some of the articulating instruments. Some of them are quite flimsy and quite expensive, and we've actually turned to using straight instruments, again of bariatric length, because the further away the handle of the instrument is from the port, the less the handles interfere with the other instrument. And then in terms of stapling, we've modified that a little bit. Typically, as you saw in that one, the stapler was angled in from the right, just because the port is to the right of the umbilicus. Actually, given some of the restrictions on the articulation of the stapler, we've taken to doing more of these from anterior to posterior.
All righty. Thanks for answering that host of questions.
Yeah, hi, Justin Somerville from Baltimore. A little bit along those lines. First of all, what size EEA stapler do you use? Do you find it better to use a smaller size EEA staplers for these double stapled low anastomoses? And then number two, obviously the big concern I think with leaks are related to the staple, the transverse staple and the circular staple are kind of coming together, whether an AP transection versus a more transverse transection is problematic.
And we're going to just pass that along the line.
Yeah, I typically use a 28 EEA. I don't like to go smaller because I think that causes strictures. I find very few adults I feel comfortable dilating up to a 31, so my default is a 28. This little lass, she was tiny little thing. Her anastomosis was 2 centimeters above the dentate line. I know it looks in that video like there's more mucosa left there than that, but we had actually dissected into the intersphincteric space in order to facilitate the stapling.
Giovanna?
We use EEA33.
Sorry?
EEA33.
28.
And I would say that I would echo what Tonia said. I don't like going less than 28 or 29, but the larger staplers, particularly in the low anastomosis with a pouch, I'm always scared to use them. A lot of times your anal rectal remnant doesn't even facilitate holding that very well. So. And so the questions come up on the computer about using things in 3 stages. Tonia, they want to know if you do that single port, and if so, where does the SILS fit in with a 3-stage procedure?
Yes, I've done some 3-stage procedures this way. Typically, in my practice, we don't see a lot of very acute patients as an indication for a 3-stage. The ones we see for a 3-stage are those chronic disease with malnutrition, weight loss, and within the treatment period of one of the anti-TNF agents. And those are the indications classically are most common in my practice for a 3-stage. If I've done the first stage as a single incision total colectomy with a Brook ileostomy, when I go back, I take the ileostomy down, I put a port through the ileostomy site and do the completion proctectomy, single incision as well. Typically, these patients have no or minimal adhesions. One of the things that can facilitate the completion proctectomy that we didn't show in this one is, first of all, leaving the superior rectal vascular pedicle intact so that the rectum stays suspended and you're not using an instrument, wasting an instrument to suspend it, and actually using a sizer in the rectum, which will help to manipulate it from side to side and anteriorly to expose the presacral plane.
One of the earlier speakers have shown a slide.
If you could just give us your name and location.
Maher Hutama, I'm from Phoenix, Arizona. One of the speakers earlier has shown us a slide why single incision laparoscopy procedures is a better way to go, and one of the reasons was shorter operative time. I understand what other speakers also have said, and in my little experience, that single incision is more challenging and actually increases a little bit of operative time. And I understand also there's a learning curve, but I'm not sure I can understand how the operative time will be shorter compared to multiple port procedure. Could you explain that?
I completely agree. That was a finding that we were surprised by, because it certainly feels like it's taking longer while we're doing the cases. I think part of it is only making that first incision, putting in the port. You're not having to put in additional ports. You're not having to close additional skin incisions or port sites at the end of the case. Plus, there's obviously, this is retrospective match series, there's bias in there. So I think the patients for single incision are very carefully selected to start with to make sure we didn't have any increased complications. We were not doing heavier patients, so that they were favorable patients.
You know, to chime in on that, we actually case matched ours to all those things and were surprised to find that it was shorter, statistically significant, not by a lot, but it was like 10 minutes shorter. And I think it just has to be that you're not creating those wounds and closing those wounds. And I mean, that's really all I can come up with. But others have seen the same thing.
I thought one of the things in the discussion section of some of those papers was the staff was maybe doing more of the case than a training fellow. Did you guys find that, or was that not a hypothetical explanation?
No, I mean, one of the things that has been leveled against single incision is like, well, only one person can do it, you can't teach it. To be honest, what I do is I take the camera, I take the grasper, because I can make sure things are out of the way, and my fellow does pretty much all of the case. Now, one thing I found that's very helpful is to have a 5'5" attending and a 6'4" fellow, because he reaches over me. You know, we're in close contact with the
So
instruments.
any tall residents out there, think
Please
Phoenix.
I'm Lee Nadler from Pittsburgh. A question for the panel and for you, John. A patient with ulcerative colitis and a lower midrectal cancer who you would want to, if on ultrasound is a T3 or you see lymph nodes, you'd normally want to treat with radiation, neoadjuvant pre-op, or would you use that post-colectomy in a pouch, knowing that the radiation is going to affect their function?
I think as a general rule, you cannot radiate a J pouch in the pelvis There's very little literature on the topic. I think relatively recent Cleveland Clinic looked at it. There's worse pouch function in a radiated pelvis, J pouch, but I don't think it's a contraindication.
Yeah, I would do standard neoadjuvant chemoradiation, advise the patient that, one, they're at risk for local recurrence, as with any rectal cancer, but that risk is relatively low. I don't think it precludes a pouch, but they've also had radiation to the sphincter, which is going to compromise their function, so their function's not going to be as good as it would be if they were just going for a J pouch, but I would not go straight to an ileostomy without giving them at least a trial of what their function's like.
And I would say that I think it's a very nuanced conversation. Clearly, the function is, I would not ever do the surgery and then irradiate the pouch afterwards, because that's going to be a functional disaster. I think that functionally it's a problem because the sphincters have had irradiation, as well as the small bowel always gets some irradiation, and that's an issue if you're going to create a pouch in there. So we would probably be, we're a little more selective in terms of using radiation in that situation, recognizing, you know, there's a long discussion with the patient. There is the kind of European approach in terms of threatened margins and saying if it is T3 or node negative, or sorry, node positive, but it's within the mesorectum, that they've had good results doing TME and not irradiating those people. So there's definitely a give and a take. You're going to give something from a cancer protection if you're going to try and create a pouch. And so I think that has to be a long discussion with a patient. The good news for these people is that they're generally a younger patient population. The older patient population, I think, is just a bad idea.
Also, if you're going to irradiate these people pre-op, would you, in order to avoid radiation on the ileum, would you consider using a sling, like, you know, a biologic sling to keep the small bowel out of the pelvis?
I don't have experience.
I'm not sure that there's any reason to give radiation post-operatively. You've already staged.
Pre-op.
Pre-op.
For neoadjuvant, so that you're not going to irradiate the bowel that you want to use for your pouch.
I think I rarely, if ever, see any small bowel damage in our patients. I think the typical techniques that our radiation oncologists are using with bladder filling, positioning of the patient, and specific focusing of the beams is perfectly adequate.
I think the short answer to that is no. I don't think there's any experience really doing that.
Okay. Thank you.
Hey, there's a question here from the computer asking, when choosing between double stapling and mucosectomy, is the presence of extraintestinal disease relevant? And if unhealthy mucosa was found and is present in the remnant, how are you surveying that?
Unhealthy.
So the question one is how do you choose between a double staple or when you do a mucosectomy? And is the presence of extraintestinal disease relevant to that? One. And then two, if there's dysplastic mucosa that's left behind, how do you keep an eye on that?
Okay, so number one, we know some studies have shown that extraintestinal manifestations and primary sclerosing cholangitis, this is all factors that can increase the risk for dysplasia and cancer in the pouch. Not uniformly, all studies have shown that, but I would still do a double staple. I would not do a hand-sewn for the reasons that we explained there. And if we happen to do a double staple anastomosis and there is dysplasia left, I would keep a very close surveillance on this patient with biopsies every 3 months, if any necessary, even examine the anesthesia. But the studies also have shown that this dysplasia many times can regress, not necessarily progress to higher grade or even cancer.
Well, I'm sorry, we're going to have to cut off the questions. I'm sure many of the faculty would be happy to answer on the side. Thank you very much to the faculty for excellent presentations, as well as the audience for your attention.